formally welcome us to the August 2024 meeting of our group. And today it's going to be very exciting. I am very, very, very happy to moderate this session today, as you probably will hear later on, because today we have a pediatrician in private practice that has distinguished herself in so many ways. But I'll say a few more words about her later on. So I want to formally welcome Dr. Olusanya as our presenter for today. But in our usual tradition, we'll ask the president of the guild to say one or two words before I introduce the presenter, and then she can make her presentation. So over to you, sir.
Okay, good afternoon, everyone. I hope you can hear me.
Loud and clear, sir.
Yes, you can.
It's showing that my
we've lost you.
We can hear you now.
Slow. Is that clearer? Is that clearer now?
Sir. Go ahead, sir.
Okay. Well, just to join Dr. Eletu in appreciating Dr. Olusanya for joining us. It's a pleasure to have her. She is an authority as far as hearing is concerned, both for children, infants, and adults. And apart from her Center for Healthy Start Initiative, Phoenix Center is a household name in Lagos, and she's helping so many people, children, infants, and even senior citizens like us. So it's a pleasure to welcome her. I look forward to a very, very interesting lecture. This topic is so important for practicing pediatricians, because more often than not, you are the first port of call, either when the parents suspect that something is not okay, or if you through your processes of examination, you discover. So it's very important for us to be at the cutting edge of our knowledge and expertise in this regard. So I joined Dr. Eletu in welcoming her and welcoming everybody to this meeting. I expect a very, very interesting meeting. So thank you very much. Over to you, Dr. Eletu.
Thank you very much, sir. I will just read a very brief resume of our presenter for today. And the topic for today is the role of the pediatrician in managing infants with hearing loss. Our presenter for today's presentation is Dr. Bolajoko Olusanya, MD, PhD. She's a Nigerian UK trained developmental pediatrician, PhD in child health, audiovestibular medicine from the University College London. She's the executive director of Center for Healthy Start Initiative, which is an organization in consultative status with the United Nations Economic and Social Council. She's also the medical director of First Years Medical Center and Phoenix Hearing Center here in Lagos, Nigeria. She has authored over 250 peer-reviewed articles spanning pediatrics, otolaryngology, audiology, general stroke rehabilitative medicine, maternal and child health, and international health policy. Her specific work is inspired by her personal experience in inclusive education with congenital bilateral hearing loss, and uniquely focused on community-oriented management of developmental disabilities, including early detection and interventional program, as well as prevention of avoidable causes. She pioneered the largest hospital-based stroke community-based universal newborn hearing screening program in Africa and in Nigeria from 2003 to 2008. And she was a leading contributor to the current WHO classification of hearing loss. She's an active collaborator with the Global Burden of Disease Study and the coordinator stroke co-founder of the Global Research on Developmental Disabilities Collaborators. In 2018, she received the Eram Loring Award by the International Society of Audiology in recognition of her contribution to global hearing healthcare. She's a co-chair of the Lancet Commission on Hearing Loss and a passionate advocate for children with disabilities, accountability, and decolonization in global health. She's listed, please listen carefully to this, she's listed among the world's top 2 most cited scientists and has been awarded a lifetime highly ranked scholar status in hearing loss in the developing country in the field of public health by Global GPS. Now, that is just a brief summary of our presenter for today. But for me, especially, it's been the honor of my life, I would say, to introduce her to you. She was my senior registrar when I started residency program, and I used to look forward to those days when we were on call. For those who are not in our unit, you missed a lot. So, Dr. Olusanya, I present you to the group for your presentation. Thank you very much.
Dr. Letu, thank you very much for that introduction. And I want to thank you for mentioning the time that we were together as residents. And I must also mention that you were a fantastic junior resident. And I'll never forget that you covered me up when I was too ill to do the job that I was employed to do. So thank you very much for those days in Louth and for covering up for me. I'm going to share my screen now. So today the topic is the role of pediatricians in managing infants with hearing loss. And the context for the presentation I have borrowed from UNICEF. Never mind that I always attack UNICEF in a lot of my write-ups. But this is especially important for us as pediatricians. What UNICEF said here is that every child must be ensured the best start in life. And this is the reason why they should be ensured the best start in life. Their future, and indeed the future of their communities, nations, and the whole world depends on it. And you will soon find out in a moment why the future and indeed that of the whole world depends on it. I would like to introduce what you haven't heard. You know, you have heard that I'm a pediatrician in audiovestibular medicine, and a life-changing incidental diagnosis of congenital hearing loss at the age of 33 years changed my view of the world and the things that I do. Now, looking at the audiogram below here, it shows a cookie bite syndrome, a cookie bite audiogram that is exactly a mirror image for each of the 2 ears. This was conducted a year after the diagnosis was made. And I was looking for the reason why I had that hearing loss that we all missed throughout the years that I was born. I have included this picture when I turned 1 year old. And you know, in Nigeria, when a child turns 1 year old and is able to walk and stand and use all the motor skills, as you can see in that picture, we throw up, we call the Atilogu dancers, and we set up a great party. So I had a nice party. I was okay as a child, and we all missed the fact that I had a hearing loss that was going to affect me throughout my growing years. So what was my growing up like? You see, I was a perpetual victim of misunderstanding, naming all the time, but refused to be changed. And my passive attributes were troublesome, quarrelsome, argumentative, rude, disrespectful, and an uncle nicknamed it Trouble. And I seem to like that nickname. So I would dance to it, but I refused to be shamed. And in my teenage years, from some of my colleagues, for a colleague of mine that isn't here today, I also learned that I was named snobbish and proud. But the real me felt discriminated against. I was always defending myself, angry, aggressive, and rebellious. But the real attributes were revealed in a well-structured boarding school where I displayed the attributes of being hardworking, kind, helpful, and brilliant. And brilliant because I had an advantageous position in class, front row bencher. There were no distractions because I never heard whispers anyway, and that could have been the reason why I was referred to as snobbish and proud as a teenager. So hearing loss incidentally revealed during my year abroad now propelled me to do a study among school children for my Part 2 pediatric exam. And I later pursued a PhD in audiovascular medicine and became a global burden of disease collaborator. So what were the skills that helped me to survive? You see, unintentional self-skilled learning, I found, was the major one. And reading lips and facial expressions become second nature. That helped to augment my understanding. It helped me while watching television with others, in group situations, and as a cue to other environmental sounds such as a doorbell. Why did I need it as a cue? I was the youngest that could open doors in the house, and anytime the doorbell rings, everybody screamed at me. But I never heard the doorbell ring. So I had to look out. Before they scream, I go to the door to check. So I looked for cues. But I also had an intentional self-skilled learning by using the mirror. Mirror, in my case, at that age, wasn't to make up and look lovely. It was really to learn to practice sounds that I couldn't pronounce properly. And in fact, at that time, I was stigmatized. But by watching with my face, with my reading lips and practicing in front of the mirror, I got to learn to pronounce the words very well. So, having to do today. Now, newborn hearing screening is a standard of practice in most developed countries, and a lot of developing countries, especially the Sahara region, are now joining in, but not yet so in Nigeria. So for generations, ensuring child survival has remained the foremost priority in all countries. And this is reinforced by the child survival revolution launched by UNICEF in the 80s. The surge in development assistance for support for health also kept it going. This funding support has been driving the declining global under 5 mortality that we experience, and also the global report in 2023 confirmed this improvement in life expectancy at birth from the decline in mortality. So what is the global perspective of hearing? Annually, about 700,000 children, roughly 6 per 1,000 live births, have sensorineural hearing impairment in the 4th month of life, compared to 28,000, around 2 per 1,000 live births in high-income countries. But there's still persistent failure to recognize that hearing loss is an important health condition, especially within our own health system that is overburdened by fatal and communicable diseases where resources are inadequate. Optimal early childhood development recently emerged as the key to productive and healthy aging in all populations. So hearing loss is present at birth, 6 per 1,000, but it continues to grow throughout the lifespan, so that by the time we turn 75, and we are all going towards that end now, more than one person out of 2 will have hearing loss. So we are looking at 55% of elderlies with hearing loss. In fact, up to 60% of them may have hearing loss. So as we all to today's presentation, it's relevant to us as pediatricians because we look after the young ones, but also as individuals because we will live, by God's grace, to be over 75. So in low and middle income countries, the nature of hearing impairment as a hidden handicap makes it difficult for us to convince parents and caregivers that their children have hearing loss at birth. To compound that is the cultural and religious norms that militate against early acceptance of the diagnosis. So you have this diagnostic odyssey where parents go from one parent to another to find out what is wrong with their children. But this is changing now because we have declining global under 5 mortality rate from 1 in 11 children in 1990 to 1 in 26 children in 2021. And this is a testament to the life-saving impact of substantial international funding for health. Now, hearing loss is a well-being condition. It is not recognized as an entity in the SDGs, but is an integral part of early childhood development, which is the main thrust of SDG 4. Its relationship with other well-being conditions is critical to its recognition as an important health condition in global health. And like I said, the WHO's universal screening for newborns in CRO now includes screening for hearing impairment, eye abnormalities, and neonatal jaundice for the prevention of disabilities. So the landscape is actually changing. So what is the prevalence of hearing loss in Nigeria? From our study, we know that up to almost 10% of infants in the community had hearing loss. And those born in hospital, we had about 2.5%, which gives us a total prevalence of about 7%. So what are the risk factors? I have put these risk factors here because it is important for us to know that things that we treat that are important, that we see every day, also have an impact on hearing loss, which is neonatal jaundice. Neonatal jaundice is on top there, and the other things that we know. So jaundice that we see on a regular basis is also a cause of hearing loss. So now we will consider hearing loss within other developmental disabilities, because we know that on its own doesn't look impressive. But when combined with other disabilities, it becomes formidable enough to have a voice in global health. But before I go into that, there's some terminologies that we need to understand because they're going to be useful for us. And that is optimal, critical, or sensitive period, which is a period of the greatest plasticity or adaptability of responsiveness of the developing brain. So there's substantial evidence that learning and development are at their highest around this time. And the birth to first year of life covers this period for hearing impairment. The lack of stimulation, on the other hand, during this period of greatest plasticity or responsiveness can lead to sensory reorganization or invasion, as I learned from someone's presentation, by other sensory areas such as vision, so that when we are now ready to help, the brain cells have moved to help vision and need to come back. So early detection and intervention is another term. And identification of a child's special needs within this period, which we call early identification, brings opportunities for timely intervention. Now, early means several things to several people. Some people will say when they visit their doctors, and this shouldn't be happening with pediatricians, that their children cannot talk. They will say, wait until the child is 5 years old. And you will see the reason why that is wrong in a moment. So early intervention that flows from early identification is capable of reversing sensory deprivation and to redefine the child's developmental trajectory. So let's go to human brain development. That takes us back to embryology. And here I want us to consider the three graphs that you can see. The first one in blue is that for hearing and vision, hearing and seeing. The next one is receptive language and production, speech production. And the third one is the cognitive functions, the higher functions. And it goes from conception to death. So let's consider the first one that is relevant to us. That's hearing and vision. And here you can see that before the child is born, a lot has happened with hearing. And you can see this graph going almost vertical, so that the child is born. Hearing is almost at its peak in terms of development. And then within 3 months, it reaches the peak and then plateaus by 6 months and drops, so that by 1 year, most of the growth has happened. And then by 5 years, very little is going on. If we were to compare it with the others, you can see that the receptive language and speech moves closely, later, but very closely with hearing and vision. But the higher cognitive functions really take their time. And that is why you can come up with your treatment plans for children with motor difficulties, all that later in life, and you will still be able to achieve a lot because it has a longer period of time for growth. So that takes us to what we need to understand about hearing in children. Priority attention must be for hearing and visual impairment prevention in early childhood, because we know what it takes for the children to move quickly and optimize the period that we have for greatest plasticity. And applying the rule of rescue for optimum outcome is the best way to do it. It's prone to irreversible consequences for a missed opportunity. And in newborn screening, we use the 136 rule for infant screening. And the reason why we do that, if you remember the graphs, is that by 1 month, we want to have detected. By 3 months, we want to have made the diagnosis. By 6 months, we want to have started the child on hearing aids for the best outcome. But because of delays at different stages, that has now become 1, 2, 3 rule for the best possible outcome. So that by the time you feed the child still has the time to grow and to get the best out of the plasticity of the growing brain. So the goal of early hearing detection and intervention is that of early help through early intervention, when you have opportunity for early social adjustment and acceptance. You have brought again the rule of rescue here, utilizing the critical period for timely intervention and a better future for the children. Here, early auditory input at the critical period will cause a reversal of auditory disruption and give us the opportunity for commensurate speech and language development. So, how do we then overcome the challenge of no action in global health? And the reason why I've brought this is because in 2007, when I came into global health, children with disabilities were excluded from early childhood development program because of lack of population level data. And with global health, when no data means no problem, and no problem means no action. So from 2018 till date, we have been busy producing advocacy-ready data for prioritizing children with developmental disabilities in global early childhood development programs. And here is what we have for children with disabilities under 5 in 2019. And the key points are that globally, the risk of disability, which is in green, is 10 times greater than the risk of mortality in red. Inequality is likely to worsen with continuing exclusive investment in child mortality reduction, and there's no global strategy to address this health inequity. Not only that, to amplify our voices, we capitalize on the synergistic effect of other disabilities. Now, if you look at the blue circles, that represents hearing loss, among other developmental disabilities like ADDH, ASD, vision loss, epilepsy, and intellectual disability. But when you combine them all together, you see how tall we get. So even though it is number 2 under 5 and number 1 under 20 years, we become much greater and much more influential when we have this synergistic effect with other disabilities. UNICEF data in 2021 also give us more information about children with disabilities. And what it has shown us is that all these parameters are much more in children with disabilities. Being unhappy, never attending school are at the bane of the problems that children with disabilities have. And so I have put that in a graph to emphasize a few of those qualities. Now, over 50 or around 50% of children with disabilities are more likely to have acute symptoms of respiratory infection, so more likely to be sick. These are children that are not likely to be happy. And when we say children are happy, they're either in pain from physical, mental, or abuse, or sexual abuse, as you can call it, and more likely to have never attended school. These are children that will be locked up in the house or left in the house and are not even brought out to interact socially. And over 40% of them will have problems with school, drop out of school, and not understand numeracy or foundational reading. So what are the barriers to early childhood development for disabled children? Global attention is one of the things. A lot of attention, endemic malaria, high mortality infectious diseases like HIV, COVID-19, and also vaccine preventable illnesses are taking a lot of our attention, and we don't have the time for children with disabilities. There's also a plethora of actors in early childhood development, like nutritionists, anthropologists, educators, economists, and biologists, and they have a right to be there. You also have diverse disciplines, such as pediatricians, psychologists, neurologists, behavioral scientists, speech and language pathologists, and physiotherapists, What we need is to be able to work together and not against each other. On top of that, we have this plethora of terminologies. The preference now is very high for non-medical social concepts, and the use of conflicting terminologies such as early childhood care and development, early childhood care and education, early childhood development and education, early childhood education also causes a lot of confusion. So where is the pediatrician in all of this? In global health, pediatricians are supposed to be the healers and advocates for children with disabilities. They're supposed to be proficient. They're already proficient in prioritizing the care of sick children, and they recognize the significance of setting priorities in health interventions. Unfortunately, early childhood development is on the back burner in clinical training. So the problem of hearing loss is relatively non-fatal, and therefore consequences of inaction are hidden. Affected individuals are unable to communicate problems to the wider society, and this leads to isolation as the inevitable consequence of our communication age. But even the primary prevention strategies, screening, has its problems. Vaccinations are not widely available for rubella, mumps, and Haemophilus influenza type B, and single-dose measles vaccinations have been found to be ineffective, but I know that there is a study going on for multiple vaccinations, and there's poor uptake of maternity antenatal services for things like maternal hypertension, eclampsia, and emergency cesarean section is preferred to the planned cesarean section or elective cesarean section because of cultural values among our mothers. The problem of secondary prevention is that up to 50% of infants with hearing loss may not have risk factors. So if we are looking for risk factors, we are not going to find it. So we're going to miss them. And available data on risk factors are limited to developed countries. So secondary prevention requires universal hearing screening to determine risk profile for targeted screening. So again, the problem of cost will come up for secondary prevention. So targeted screening is not ideal, but it's inevitable, where it is the only realistic option as a first step towards universal screening, and is a valuable pre-screening tool or an essential guide to primary prevention. So we have challenges. Our streets are noisy, our hospitals and health centers are located right inside these noisy environments. And the follow-up default, which is also a global problem, plagues us in this environment as well. Again, I have put the risk factor up because I'm going to mention neonatal jaundice as an important risk factor in our environment. So this has led to a few publications from us. And also, I will show you this picture because I want you all to live here. I know you are familiar, but I want you to live here with the shrill cry of this infant. This is a 7-day-old infant that came in with a bilirubin level of 45 milligrams per day. The child eventually had EBT, which was very instrumental to his development. At that time, I did not believe that we could help the child. In fact, I told the grandmother was there. I told the mother and the grandmother that there was no point doing anything for that child. That was already too late. But they wouldn't hear that. So we arranged EBT for the child. And today, the child is doing extremely well. I have presented this everywhere, and nobody believes that EBT can do that much. So those of us who are very hardworking and busy doing EBTs, please don't stop. They improve the outcomes for our children. So what are the options for us pediatricians? We know that children with disabilities are of utmost importance, and they deserve priority consideration in any global and national initiatives concerning early childhood development and education. We can say nothing, we can do nothing. But can we live with the consequences of our inaction and the missed opportunity? We can say something. We can say, if it doesn't kill, it can wait. And I can understand that because we are very busy with deadly conditions, with children that come to the emergency room in heart failure and other conditions that need our attention. So I can understand. But we can do something. It is an ethical imperative for pediatricians to take a leading role in tackling the health inequalities and inequities faced by children with disabilities and their families. A developing country like Nigeria has an important role to play in low and middle income countries in realizing this global vision. And I won't end this presentation without presenting an opportunity through our topic collections that I am one of the editors. And I think I will be very happy to have papers submitted from our colleagues in Nigeria. Please share this widely. And if you have papers, we will consider them. And I hope Nigerians will publish in this topic collection. Thank you very much for listening.
Thank you very much, Dr. Olusanya. I really don't know what to say. It's been an eye-opener for me. And I must say that you've thrown a big challenge to all of us as pediatricians as to what we should do to help our children. Dr. Dayo Ajayobe is currently out of the country and she has raised up her hand. So Dayo, please go ahead, unmute and speak.
I just want to say thank you very much, Dr. Olusanya. Brilliant presentation. It's you've expanded our ability to, you've expanded our what we should be doing, but it's just more than just doing the clinical stuff. We're advocates. We're a few pediatricians in Nigeria, and personally, I believe that we need to take the big responsibility of changing the course for every child that is in Nigeria, those 18 million and 19 million children that we have. And to take on those big, laudable causes. So thank you very much. I actually appreciate the information, the years of research, and how you brought to bear on our current situation. Thank you.
Thank you. I appreciate your comment. Thanks.
Dr. Nipadi, you can unmute and speak.
Thank you very much, Dr. Olusanya. This is a wonderful presentation. It gives all of us an opportunity to see that we should not be looking at the disease alone, we should be looking at the child as a whole.
Yeah.
And making sure that as pediatricians, we're not just giving antimalarials, we're not just giving antibiotics, we are ensuring that the children achieve their best potential. This is a wonderful presentation, and it is given, I mean, it's an eye-opener. The only thing I would say, and I like your last slide that says anyone who has a presentation should come up with it. And you will review it for use on a global platform, on the platform of the globe. Again, that's the message. We need to work as teams. Together, we all achieve much. Bless you and thank you very much.
Thank you for the comment. Thanks.
Thank you. Thank you. Ian, please unmute and speak.
Thank you so much, Dr. Olusanya. I had to listen to your talk today. And I just want to say a big thank you to you for something you probably didn't recognize or remember, that you actually encouraged me, or would I say inspired me, to do neurodevelopmental pediatrics. I remember when you went abroad and came back, and you were doing all these assessments on children, and I just became fascinated and intrigued and used to follow you about when you were doing the neurodevelopmental assessments. And that really changed my perspective and was the foundation of me going further to study neurodevelopmental pediatrics and where I am today. So I just want to say that your impact had started way long ago, because I saw what you were doing and identifying those disorders, in those impairments in children very early. And I just want to say that you've thrown a challenge to us. And I think that in our pediatric training, we need to relook our curriculum for training pediatricians to include developmental disorders as a very key part of training for pediatric trainees. Coincidentally, I had a trainee with me today who's from Nigeria and had done the training in Nigeria. And one of the things we were talking about today was how she wished that she had learned a lot more developmental pediatrics and sensory impairments when she was doing her postgraduate training in Nigeria. So I think this just emphasizes it. And I just hope that we would begin to look back at all those children. Some of them haunt me when I think back about all the children with birth asphyxias and neonatal jaundice in D1 and all those children. I'm thinking, where are they now? What's been the follow-up for them? So it's not just treating children acutely. There's a lot of impairment that happens afterwards. So thank you for your contribution to developmental pediatrics and all the hearing and sensory impairment. Thank you. It was a wonderful presentation.
Thank you. I appreciate that. Thanks.
Thank you very much. There is a comment here from Chigoke, who says, thank you for the presentation. Please, do you mind having a recap of the 1, 2, 3 rule for managing hearing loss?
1, 3, 1, 2, 3.
1, 2, 3. Yes, just a recap.
Okay. The 1,
2, 3 rule.
1, 2, 3.
Instead of 1, 3, 6.
The 1, 3, 6 is by 1 month, you want to have detected the hearing loss. But you can't make diagnosis in newborns. You can say, yes, this child may have a hearing loss, but by 3 months, you make a firm diagnosis of hearing loss. And by 6 months, you fit them with hearing aids. Now, they found that because of delays, they were not achieving the 1, 3, 6 at the right time. And babies were still being fitted much later than they want. So they have now changed to 1, 2, 3. By 1 month, make sure you have detected, which means at hospital discharge, you have done your hearing test, or within 1 month of the baby being born, you have detected hearing loss, and you confirm by 2 months, and by 3 months, you fit them with hearing aids so that they can have the best of speech and language development, like you saw in the graphs that I showed, because it's still growing at that time and you want them to be exposed. With that, they are likely to be at the same level with their peers because you have helped them at the time of the greatest growth in the brain. I hope that answers your question.
Yes, ma, thank you.
Thank you very much. There's a question here a comment and a question from Dr. Waje. She says, thank you so much for this presentation. It's a great honor to finally hear you, ma. I feel very strongly about universal hearing screening. And at our center, we do hearing screening before discharge and also whenever we have a child with speech delay. When should we send for full audiometry screening or the bear test?
Yes, that's what the 1, 2, 3 is about. You do your screening by 1 month by hospital discharge, which you're already doing. And if you find any referrals, by 2 months, you want to make that diagnosis. You send them by 2 months to have a diagnostic assessment, or by 3 months in Nigeria. That will still be okay. And by 6 months, we want to be in the position to make a decision for those who need it. Sorry, I'm not hearing you again.
Sorry, Chijoke is asking that at what point should we involve the ENT team in the management of these children?
The ENTs, there's some of them that are in audiology. You have ENTs that are interested in audiology, and you can refer to them by 2 months, by 1 month. In fact, by the time you do your screening and it's positive, if you don't have a physician, because there'll be few physicians who will be doing audiology, if you don't have one, you want to involve the ENT very early.
Okay, thank you. Murtala Ahmad is saying thanks for the presentation, and he wants to know the role of the pediatrician in avoiding use of toxic medications in children who are at risk, and also wants your view on the availability of facilities for hearing loss screening in our public health sector.
Well, let me start from the last one. Facilities in the public health sector, I'm not aware yet of any, except there's one that is happening now. So the ones that we know of are all private. So like Dr. Iwaji said, that they screen in the center. A lot of the private hospitals are now doing that for their babies. Now you want to know, sorry, I lost the first question.
That the role of the pediatrician in the avoidance of use of ototoxic medications.
But I know that we can monitor, because we may not be able to avoid if we are limited by drugs or cost. If we have to use it, then we have to monitor the children. And if we can do tests, autoacoustic emissions test, we can detect early if they are there is having an effect on them, and if it's not having an effect on them. So if we can monitor them with autoacoustic emissions, that will give us an idea. If not, I think what we need to do is to avoid it completely and look for alternative drugs that may be more expensive.
Thank you. Tare Biu is asking, looks as if most of the questions are from those abroad, maybe because they see more.
Okay, they see more. Yeah.
More of these children than we tend to see them. So he's asking, what services are available for children with hearing impairment in schools?
Yes, in schools, it's tough, but we are having private schools that are evolving now. I know of one that we have supported for a while. The children started from primary, they are in the university. Some of them have graduated from universities with their hearing aids. But we need more of such. The reason why we supported them was to see whether fitting hearing aids on these children would help. And we have seen that it does help. And we are hopeful that many more will come out of this, and that government itself will buy into it and support these children. Because really all they have is hearing loss. They're still children, they still have intelligence, and they can still become the very useful citizens in the country. And in fact, extremely useful citizens, because they are more likely to be focused and less distracted.
Sorry, we lost you, Dr. Olusanya.
Oh, okay. Oh, you did.
Okay,
I
we can
didn't
hear
know
you
that.
now.
Did that answer the
Dayo,
question?
you still have a question?
To mention that thank you very much for this. I know we're having a talk next week on building services, post-meningitis with Kweli.
Yeah.
I'd like to invite everybody on for that as well.
Okay.
I think it's important that we build services across the country.
Yeah.
I know that meningitis, when it comes to WHO, they're going to use meningitis to drive building services in sub-Saharan Africa. And basically, once they build those services, then people with epilepsy, other things will actually be built on top of it. So I just wanted to mention that people are looking at this on a broad terms, and I'd like to invite you next week.
Thank you.
Thank you very much, Dayo. That's good information. Dr. Fajulu stating clearly that the major challenge for us in the public hospitals is unavailability of screening tools, insufficient manpower, as well as cost of care for the patients. So, of course, that would lead to late diagnosis and intervention likewise. Thank you very much. There's a comment here from Cressida. Is asking about acoustic emission screening is done at six months for infants. At what age do you do this test with older children?
Well, with older children, I think that's why it's called infant hearing screening for some, not just newborns. You can do it at any age. If you missed it as a newborn, you can do it as infants, and I can do it before school entry. So really, these tests are available all through childhood years, even for adults. So you can do them. It's just because of the concept of early intervention. The concept of early intervention and the fact that we want the best possible outcome. That is why we go very early, detect it early, and intervene early.
Okay, thank you very much. I think there's another question here. Okay, now just to thank you very much for the presentation. Well, I would also want to thank you, Dr. Olusanya, for opening our eyes to this challenge that we seem to miss locally. And the fact that we didn't allow this to overwhelm you and stop you from achieving your goals. And the fact that today you are a leading voice for children generally who have hearing problems. I mean, I remember reading my first primary school card where my dad was told, or my parents were told to withdraw me from school because I was not capable of formal education. It was as bad as that. But I think my parents just decided that the best thing to do was to change my school. And then the sky was now the limit. So I want to again thank you for bringing this to our attention and letting us know that no matter the challenge, we can always overcome and be the best that we can. I'm so happy to say to everybody here that I think in Africa, if not in the world, I think you are the most accomplished pediatrician in private practice in terms of paper that you've written and presented. And if you were in a teaching hospital, if it was possible to give you 2 professorial chairs, I'm sure you more than qualify for that. So thank you very much for being a role model. And also thank you very much for being a fantastic boss. Well, I worked with you. And I must say that any day you call me for anything, definitely I'll be there to represent you. Thank you very much.
I'll take you up on that.
For sure.
Thank you so much.
Dr. Mobalaji Lawal, sir.
Okay,
Comment.
so I want to join others in appreciating Dr. Olusanya for a very clear presentation. A distinguished presentation, in fact, based on many years of research and experience. It's been a great pleasure listening to you, and you have made your point very clearly. We as pediatricians must, apart from looking after our patients carefully, knowing when and when to screen and when to refer, also be advocates for children. And I think it's very important for us to put that in perspective with our local situation, because it's not by accident that most of the people who contributed today are from the UK, where services are well developed. Because by the time you have advocacy for screening and you detect them, the services just have to be available. And I think it was Dr. Fajolu who put the local context very clearly by explaining the challenges we have in public hospitals, cost of treatment, even availability of the services. So we have a huge task, but it has to start from somewhere. And that's the point we've heard very clearly today. We must start it from somewhere. And the first thing is to draw attention to it, that this is a problem, and we have to be at the forefront of pushing for it. Because, like you rightly mentioned, children with disabilities that are not apparent, they're at risk of various forms of abuse and neglect. In school, they get beaten up. They are told that they are not intelligent. So many forms of abuse. They are open to so many forms of abuse in society, and this have serious psychological and social effects on these children. So I think we must take that home. And I want to thank you again very, very much. I'm happy that I attended today, especially because it was very ably moderated by our chief coordinator himself. So, so everything has gone very well. Thank you very much indeed. And thank you everyone for joining and for participating in the usual way. Thank you very much.
Thank you.
Bye-bye.
Thank you for having me.
Thank you very much.
Thank you.
Dr. Olusanya. And once again, I want to thank everybody for creating time to join us. We shall share the slides as well as the recordings. So until we see you next month, have a great evening. Bye-bye.
Bye.
Bye-bye.
Bye.
Bye.